Hello?
Yes, sure.
Yeah. We will start this meeting now, right away. Okay,
Okay.
is it okay, Ramohan?
Yes, of course.
Yeah,
I
yeah.
was just, I had been speaking to Dr. Chilimuri all along, asking to find speakers. And as you know, even though I had not been seeing any patients, I myself was the speaker a year ago, but now it is very inappropriate for me to talk about neurology. So he kindly found Dr. Dhalu, who is in Bronx, Lebanon. He is the director of the stroke unit, a neurologist who has already been there for a few years, 4 years already or more.
More, like almost 6 years now.
6 years now, and clearly has gone through the crisis with COVID last year. So I called and asked him after Sridhar pointed out to talk about the neurological complications of acute COVID. And I also asked if he would kindly address what he thinks, what he knows is happening with long COVID, because this might turn out to be a major problem for us for the next couple of years. So Dr. Dhalu, thank you very much for coming on board. This group was very active, logging in nearly every night during the crisis in April and May. Now we meet every Saturday night in New York, and many of the local practitioners who ordinarily might not have taken care of very ill people in the ICUs were taking care of COVID patients. So our intent is to give them enough of knowledge about COVID management. And as you can imagine, originally it was all pulmonary critical care, anticoagulation, and acute injury, but has much importance for neurology now. So we are all ears. Please proceed, Dr. Dhalu.
Okay, thank you, Dr. Karaman. Thank you for inviting me for this talk. I'm going to talk about COVID-19 and neurological implications and neurological complications. First of all, we know that COVID-19 came from coronavirus disease, which started in 2019. It's been a real pandemic, and we have had like so many cases worldwide, and we're still counting on these numbers. So this morning, worldwide cases were like 219 million, and we're still counting on it, and total fatalities of like 4 million people. In USA alone, we have 40 million people who got infected, and almost like 660,000 deaths. In India, also a staggering number, like 32 million and still counting, and almost close to like 450,000 fatalities. So it has like been a real pandemic and very large impact on the whole world. Coronavirus, it's a severe acute respiratory syndrome coronavirus 2. It's a member of beta coronaviridae family. It's a mRNA, it's an RNA virus. It's a single-stranded, non-segmented enveloped virus. It was first reported in Wuhan, China in December of 2019. And the real impact worldwide was mainly seen in the month of March, when we had like staggering number of cases, which exponentially increased everywhere in Europe, in UK, Italy, US, and continued to increase after that. And there are like multiple variants have been there since then. Alpha variant, which started in UK, and then beta in South Africa, Delta variant, which really, I would say, caused a havoc in India, and so many infections and so many fatalities, unfortunately. And then Gamma variant, which started in Japan and Brazil. So we know that, COVID-19 infection, it's a multi-system infection, primarily pulmonary, cardiac, and then GI, dermatological, renal, and neurological, but I'm primarily going to talk about the neurological complications, acute neurological complications, and then chronic, COVID-19 haulers, and some in between, like psychiatric complications of this viral infections. So to name a few, we see the neurological complications like anosmia, loss of smell, agusia or dysgeusia, like loss of taste and alteration of taste, then cerebrovascular disease in the form of strokes, meningitis, encephalitis, and encephalopathies, then encephalomyelitis also, there are a number of cases which were reported, then demyelinating diseases like GBS, and seizures, which could be secondary to medication use and which could be secondary to encephalitis and meningoencephalitis cases, and then some case reports of polyneuropathy also. And whereas chronic neurological complications of this disease, many symptoms in these patients, and if we look at these symptoms, they seem very subjective, but these are nevertheless like real symptoms in these patients. So if somebody comes with like fatigue and headache, we do have to pay attention to these patients because these symptoms are really affecting their productivity and their daily lifestyle as well. So these are like real symptoms, and we have to believe so that we can make a treatment plan for these patients. And to name a few, like fatigue, lack of concentration, cognitive impairment, lack of like loss of memory, and attention span is decreased in these patients. And some complain of like generalized weakness with fatigue and non-specific headaches and dizziness. And almost like 50% of these patients, their quality of life is getting affected by these chronic symptoms. Now, pathophysiology for, in particular, neurological complications and neurological conditions, it's multifactorial. There could be direct damage to the receptors like ACE2 receptors. It could be cytokine-related injury with cytokine storm or surge. It could be damage secondary to hypoxic state, which is produced by damaging the pulmonary system in alveoli, and it could be retrograde travel of this virus along the axons of neurons once they are attached to like ACE2 receptors. So as I said before, mainly ACE2 receptors, which have been found on majority of the systems, pulmonary, cardiac, GI, even neurological, blood vessels, endothelium. So it gains access, this virus gains access to the cells after attaching to the ACE2 receptors, and which causes like a systemic inflammatory response and massive pro-inflammatory CNS state, which in itself causes prothrombotic state and further complications by causing thrombi and blood vessel blockage. Then the severe hypoxia caused by alveolar damage, that leads to like cerebral vasodilatation and cerebral edema and subsequently ischemia in these cases. And there is like retrograde transportation of this virus through the olfactory nerve and olfactory bulb when it attaches to the ACE2 receptors and goes up through the axon and causes damage in these nerves. Many of these patients, they have like the sick patients, they have prior neurological conditions like stroke, Parkinson's disease, neuromuscular diseases. And unfortunately, these patients, they have higher risk of complications, pulmonary complications and cardiopulmonary complications. And they also have increased mortality rate, with this infection. I'm going to talk about some of these conditions and we have seen and experienced in these patients. First one is anosmia, which is loss of smell. And the pathophysiology in this case is like direct invasion of the olfactory neurons, and then the olfactory bulb and the nerve getting disrupted and destroyed. And the main receptors are like ACE2 receptors, but there has been other membrane proteins of interest like basogen and neuropilin-1, which has like higher affinity to this virus, and it gets attached to these membrane proteins and gets access into the cells. Anosmia can be a presenting complaint, as we all know, in coronavirus 19 infection, and it may linger on for weeks and sometimes months in some of these patients. And sometimes, fortunately, this is the only symptom patient may experience, and young patients, and they don't have any other complications and symptoms with this disease. Then dysgeusia or ageusia is like loss of taste and alteration of taste. And it has been proposed that the sensory neurons in the taste bud, the virus gets access into that, and then there is a retrograde transportation of this virus into the nucleus of trigeminal nerve and solitary tract, which alters the sense of taste. Let's talk about stroke, which has been very common and debilitating in this coronavirus infection. And we have seen certain characteristics of strokes in COVID-19 cases, and the multiple pathophysiology proposed in these cases. It could be an indirect effect of cytokine storm and causing a prothrombotic state, causing microemboli, thrombus, and major thrombus blocking the blood vessels. It can be a direct damage to the endothelium, and which causes like platelet activation and platelet aggregation, which causes prothrombotic state again. And it could be related to the hypercoagulable state we have seen in these cases. And personally, I have not seen such a high value of D-dimers in any of previous conditions I've seen. I mean, the values are 86,000 or 100,000 of D-dimer and increased fibrinogen. So the hypercoagulable state itself can cause further problems in these patients and causes thrombi, blocking the blood vessels. The incidence is about like 1 to 6% in hospitalized patient. It varies basically. It can vary from region to region, and depending upon the population and depending upon the resources hospital has. And some of these patients, when they come to the hospital, they are really like sick patients. They are some of them are like poorly responsive, and we may miss some of these cases initially because of a poor responsiveness, and we don't get to examine the patient in a thorough way. And that's why the number is like, it varies from hospital to hospital. AHA, American Heart Association, came up with this protected stroke code. And what that means is, because stroke could be presenting complaint and presenting symptom in these patients, especially younger patients with no previous medical conditions. And so every stroke patient coming into the ED, we take that stroke patient as COVID positive patient unless and otherwise proven that they are COVID negative, because that may be the presenting symptoms in these patients. So we have to take all the precautions while examining these patients, using PPEs and minimum physical contact with the patient. And there is some literature regarding neurological examination, observational neurological examination, and instead of like touching the patient and doing everything physically. And that has come up a big way nowadays, that by just observing the patient, we can say that, okay, the patient is having a stroke or not. Then all of these patients, the appropriate treatments indicated should be instituted, like thrombolytic therapy if they are within the time frame, and endovascular intervention if they are within a time frame, and if they have any emergent large vessel occlusion disease. There's a very nice paper by Dr. Stein and his team from Mount Sinai recently published, and they looked at the population in the New York City, and I think it's true for other parts of the world and country as well, because all the literature shows a similar presentation in other parts of the world. And as I said before, the pathophysiology is like multifactorial in these patients. It could be related to inflammation and cytokine surge, release of interleukin-2, 6, tumor necrosis factor, and all those things, which subsequently, leads to prothrombotic state. And it can be related to hypercoagulability, elevated D dimers in these patients, and that also causes thrombus formation. It can be injury to the endothelium of the blood vessels, because we know that ACE2 receptors are present on the endothelium, and the virus has high propensity to ACE2 receptors, and the endothelial gets damaged, and that activates the platelets and platelet aggregation and thrombus formation and plaque formation. It can be immune-mediated platelet activation, and that can also attract like inflammatory cells and causes a prothrombotic state. And we also know that this virus affects cardiac system. It causes endocarditis, pericarditis, and cardiac injury, which can lead to arrhythmias, and the person is already hypercoagulable, so higher chances of clot formation, thrombi formation. And with arrhythmias, we see like higher cardioembolic phenomena as a cause of stroke. So I think this is a good demonstration of the potential and possible pathophysiologies in the mechanism of stroke in COVID-19. The same group demonstrated like stroke characteristics in COVID-19 infection. I think it's true for the data collected from other countries, and it's similar to the presentations people present with these strokes. As with the general population, we see more ischemic strokes in COVID-19 patients. Almost like 79% were ischemic strokes, and about 15% were hemorrhagic strokes. But we do see that there is an increased number of strokes in younger population who have no risk factors and who had like no prior medical illnesses. And some of these patients presented as initial symptoms of stroke, like dense hemiplegia. And we do see higher number of emergent large vessel occlusion, or LVO, in COVID-19 infection. Normally, it's about 35 to 38%, but in COVID-19 patients, it's more than 45%. And in some literature, it's about 50 to 60% large vessel occlusion diseases in younger patients. And we do see stroke in multiple territories of the brain. And that tells us that, yes, cardioembolic phenomena or artery to artery embolism or stump paradoxical embolism, this could be related to that. But we do see increased number of strokes in multiple territories of the brain. And we also have seen like increased cryptogenic strokes because these people, they have no risk factors before, and we don't know the explanation for them having a stroke except for COVID-19 infection itself. And the number of cryptogenic strokes actually are more than double compared to the general population and COVID negative population. Then we do see, unfortunately, higher rate of deaths. Mortality in these cases is about like 35% compared to similar strokes in COVID-19 patients. It's about like 6%. Interestingly, these patients, the large vessel occlusion patients, they were more male genders, like in men. And interestingly, they're more in Blacks and Latinos compared to white population, because as we all know that large vessel occlusion disease and extracranial carotid artery disease is more common in whites compared to Blacks and Latinos, and Blacks have more small vessel disease, intracranial and intracranial atherosclerosis. But with the COVID-19 patients, we have seen that more number of large vessel occlusions in Blacks and Latinos compared to whites. So that's an interesting fact. Then another thing they noticed, their group, and it's that patients with LVO who were candidates for thrombectomy, the COVID positive patients, even after getting the thrombectomy done, they had longer hospital stay. And unfortunately, they're more likely to die, compared like 30% compared to non-COVID patients, which is approximately 13%. Now, the reason for that, that does not mean that thrombectomy was not useful in these patients, and it's not indicated in these patients, but due to the multi-system involvement of these patients, they have poor pulmonary functions, they have poor cardiac functions, and renal involvement and GI involvement. So I think it's a multi-system involvement which puts them in this situation, and that's why they have a higher mortality rate. I think the mortality would have been much higher if they were not subjected to thrombectomy or any intervention. Hemorrhagic strokes, they were less common as with the general population. So about 15% were hemorrhagic strokes. But as we know, with the hemorrhagic strokes, most of the hemorrhagic strokes are hypertensive. So they're mainly present in putamen, like basal ganglia, pons, cerebellar, thalamus. But there are very few hemorrhagic strokes, hypertensive hemorrhagic strokes in non-COVID patients, which are lobar. But in this population who are COVID positive, we saw more number of lobar hemorrhages and cortical hemorrhages as well. So that's another like a different presentation we see in these patients. And majority of the COVID positive stroke patients, they had a longer route to recovery, and they were more likely to be discharged to other facilities rather than home. So COVID negative patients who presented with stroke, they were more likely to, some of them are more likely to go home, but these patients were more likely to go to subacute facilities and acute rehab rather than home. And that could be related to, again, multi-system involvement in these patients, and that could play a big factor. I have some pictures, and we can see in picture A, which is on the left side, a dense right MCA sign. That means there is a thrombus sitting in the right MCA. And the CT angiogram also demonstrates the same thing. There's a cutoff of the right MCA. And this is a demonstration of large vessel occlusion, and in fact, emergent large vessel occlusion. And subsequently, the patient ended up having a huge right MCA distribution stroke. I'm going to go a little bit, sidetrack from here, but I'm still going to talk about thrombosis and strokes in these patients. But Um, uh, we have like vaccine-related thrombosis and thrombocytopenia syndrome, and thrombotic episodes, vaccine-related. So I'm going to talk about like in 2-3 slides regarding this. I think this is an important condition to identify, to recognize, and because they have like higher fatality, and so that we can recognize it early and institute the treatment for these patients. I mean, no way this should be a deterrent to like not getting the vaccine, but as we know in the medical community, we need to recognize these patients and to know the complications which are vaccine related, so that we can identify these patients and treat these patients accordingly. So we had an interesting case in our hospital. We had a 56-year-old woman with past medical history of hypothyroidism and hyperlipidemia, fairly well controlled. She was euthyroid on Synthroid, and her hyperlipidemia was also well controlled on atorvastatin. So she had like fluctuating mental status and left-sided weakness and generalized headaches for the last 1 week. So headache started first, and then the mental status, and then she developed left-sided weakness. Interestingly, she received the mRNA Mrna vaccine 12 and 18 weeks prior to this presentation. So almost the first dose was given like almost 3 months before this presentation. On examination, her vitals were stable. She was in distress because of the headaches. She appeared confused, and she had like 3 out of 5 left hemiparesis. So the initial CAT scan showed multiple hypodensities, and some of these hypodensities showed like hemorrhagic component also. So initially we thought, yes, this could be, vasculitis kind of picture in a young, like in a 56-year-old woman, and this could be metastatic disease, or this could be like multiple embolic strokes. It could be cardioembolic as well. We got the MRI and MRV done. Interestingly, she had like watershed infarcts, bilateral, and she had this extensive sinus venous thrombosis in the superior sagittal sinus, the left transverse sinus, the sigmoid sinus on the left, and the left internal jugular. So it was a like pretty big thrombus sitting in the durovenous sinuses. She was started on anticoagulation, and she was transferred to Mount Sinai, which is a tertiary care hospital we are affiliated with, for possible intervention and to do like a venous side thrombectomy. Unfortunately, she had that intervention the next day, and after 2 days, she started recovering, and she was moved to the step-down stroke unit and then subsequently to the floors, and now she's in rehab. So we're glad like she did so well. This is the initial CAT scan of the same patient. We see this hypodensity in the right frontal region, and on the left side also we see this small cortical hypodensity, and the right frontal hypodensity turned hemorrhagic, and in fact the left one also turned hemorrhagic a day later. This is the MRI, the diffusion weighted image of the MRI on the same patient. This is the apparent diffusion coefficient image, and the ADC showed that she has these watershed kind of infarcts bilaterally and with some hemorrhagic transformation. And ADC complemented the same what we saw on the DWI images. The MRA did not show any abnormality. There was no cutoff sign, and there was no sign of vasculitis or beading in these blood vessels. And interestingly, the MRV showed that the superior sagittal sinus was completely gone. The left transverse sinus was completely blocked, and the left sigmoid sinus was almost gone, and there was no internal jugular vein drainage, whereas the right side was pretty intact. So she was diagnosed with, as I said before, the dural sinus venous thrombosis, was started on anticoagulation and transferred for thrombectomy. Again, I mean, there has been case reports, almost like 39, but I was checking today's numbers. I think it's more than 39 now. Out of 13 million people who got vaccinated with the Johnson & Johnson vaccine. And there were 2 case reports, but I think it's more than 2 now, with Mrna vaccine administered in like 328 million doses administered already. But the mean duration of these patients in this literature was mostly up to 48 days, and the median duration was like 14 days. In our patient, it was more than 3 months, I would say. And we know that vaccine-associated thrombosis and thrombocytopenic syndrome, it can cause thrombosis in venous side, it could cause thrombosis in dural sinuses, cause coronary artery disease, pulmonary embolism, mesenteric artery blockage, and venous thrombosis. The CDC came up with a definition of thrombotic thrombocytopenic syndrome as like tier 1 and tier 2. And the tier 1 is thrombosis in unusual locations and thrombocytopenia less than 150,000 platelets, and positive platelet factor 4 antibody, which is not required for this diagnosis, but it's supportive. And if we see most of the literature, majority of these patients, they had platelet factor 4 antibody positivity in these cases. And then tier 2 is thrombosis in a common location, thrombocytopenia and positive platelet factor 4 antibody. Then there are case reports of vaccine-related arterial site thrombosis also. And recently, Dr. Mehani and his group from UK published, 3 cases, and they received Oxford AstraZeneca COVID vaccine, and they presented within 6 to 21 days after getting vaccinated. One case was of MCA blockage and MCA thrombosis. The second case had bilateral carotid artery thrombosis and sinus venous thrombosis. And the third one had like cortical artery thrombosis in the M3A distribution. So all these cases presented with a different arterial blockage, large vessel and small vessel as well. And all of them, they had raised D-dimers, they had thrombocytopenia, and all of these cases were positive for PF4 antibody as well. Unfortunately, the one with the MCA thrombosis, she died because of massive edema and herniation. And the other 2 were successfully treated with IVIG, plasmapheresis, and indirect factor 10A inhibitor anticoagulant, and suggesting that most of these cases are immune mediated thrombocytopenia and thrombosis. So I think we might see more arterial side thrombosis in these, but it's important to recognize these cases and early on, and as a potential complication of vaccine, and then treat these cases accordingly, because otherwise they can have a higher mortality and fatality. This is a paper by Dr. Takwet and his team in Oxford, UK, and it demonstrates the probability of all these conditions like ischemic stroke, hemorrhages, and the flexopathies, and the dementia and psychiatric cases is higher in COVID-19 patients compared to the other respiratory viral infection. I think this is important because the follow-up was up to like 180 days, and they still see like higher dementia and cognitive problems in these cases. The next entity I want to touch base is encephalitis. And interestingly, we also had a case with encephalitis. This was a 66-year-old man, and initially he presented with the pulmonary symptoms. His COVID positive, he was like RT-PCR positive for COVID-19. Subsequently, his status improved, but he started having seizures, and he still remained with altered mental status. And that was not explained because his cardiopulmonary status was improving, and but his mental status was not. So we did the MRI in this case, and the MRI, I'll skip this. MRI showed like focal cerebritis on a T2 flare images, and white matter lesions and periventricular enhancement on T2 flare. And so that tipped us over for like focal cerebritis or encephalitis. We tapped this patient, and the CSF was with high proteins, I think around 92, and but it was negative for the viral RT-PCR, which is consistent with most of the literature. Very few cases have demonstrated the positivity in the CSF of this virus. And initially, he was treated with IVIG, and he also received tocilizumab, but he was still not getting better. And I think we got desperate to make him better, and we tried rituximab, which is a monoclonal antibody, and he had like significant improvement after that. We saw him after discharge. He went to subacute rehab and then came home, and he did much better. He was still a little confused, and there was some cognitive slowing, but he was able to take care of himself, his daily activities, and his repeat MRI showed like complete resolution of these T2 hyperintensities, what we saw before when he was in the hospital. Yes, encephalitis can be a dreadful complication of COVID-19. The average incidence shown by this group is also from UK, that the average incidence is less than 1%, but the incidence in severe COVID-19 infections, severity meaning these patients were ICU, admitted in ICU, they required cardiopulmonary support, and they were intubated. In those patients, the incidence was up to like 6.7%, and the mortality rate in encephalitis patients was very high. It's like 13.4%. And again, it can present in the form of like acute disseminated encephalomyelitis. It can, there are case reports of necrotizing encephalitis with hemorrhagic transformation and autoimmune encephalitis. And the majority of these cases, they had one comorbid condition like hypertension, hyperlipidemia, diabetes, and they presented with altered mental status, weakness, fever, vomiting. But it was rarely a presenting symptom for COVID-19. So these are the cases who were admitted with COVID-19 infection and subsequently developed, encephalitis and brain infection. The MRI in these patients, it shows like T2 hyperintensity and some hemorrhagic lesions, and CSF. Majority of these patients, they had high proteins. Some of these patients demonstrated a higher number of cells like RBCs and WBCs, but majority of these patients, they did not have positivity for RT-PCR for this coronavirus too. And they got treated with corticosteroids, IVIG, plasmapheresis, rituximab, monoclonal antibodies, but still, we are still early on treating this entity with COVID-19. And I think it's still, we need to see what should be the right way of treating these patients. and it could be related to direct viral infection of the brain tissue. We know that it infects microglia and neurons. It could be related to the inflammatory injury, and it could be immune mediated as well. Then I would touch base with complications like GBS. And as we all know, that acute inflammatory demyelinating polyneuropathy can happen after any GI infections or upper respiratory infections. And same is true for COVID-19 infections. And there's a cross-reactivity to myelin of these antibodies to myelin sheath, which are produced to fight coronavirus 2 infections. Usually, and normally, most of these cases present with ascending paralysis, loss of muscle tone, and they can have diminished or absent deep tendon reflexes. And if the case is really severe and not identified early on, they can have respiratory muscle involvement, and they can go on to intubation and cardiopulmonary support. Atypical presentation is always there. Sometimes GBS can present an asymmetric, one-sided of the body, and sometimes it's not always ascending. And there are variants of GBS which can present as cranial nerve involvements also. And diagnosis, as we all know, it's based on the history, the clinical exam, the CSF examination, EMGs showing conduction blocks in these patients. And sometimes MRI of the spine is helpful. We do see enhancement of the nerve roots in these patients because of high proteins in the CSF. We also had a case, an interesting case of facial diplegia. This was a young patient, and he presented with the bilateral facial weakness and alteration in taste sensation. He had coronavirus 2 positivity, and these symptoms probably started a week or two later with his facial involvement. And this patient was tapped, and he had elevated proteins in the CSF, and his CSF RT-PCR for coronavirus 2 was negative, and the brain did not show any pathology on the MRI. And this patient was successfully treated with a course of 5 days of IVIG, 4 grams per kg body weight divided in 5 days, over the 5 days. And luckily his symptoms improved, and we published this last year in American Journal of Case Reports. So those were mainly the neurological symptoms. We have seen a number of psychiatric symptoms in these patients. Post-COVID, they have higher incidence and rates of depression, anxiety, PTSD, and some of these, there are multiple factors and multiple proposed pathophysiology in these cases. It can be due to direct neurotropic effect. It can be due to powerful immune inflammatory response. We've seen that mood disorders and inflammatory cytokines are interrelated. They have positive connection with the two, and it could be activation of certain enzymes which can degrade tryptophan, which is essential in production of serotonin, and we can have less serotonin in these patients. Majority of these patients, anxiety was the main disease, psychiatric illness, followed by depression, insomnia, and PTSD. And PTSD cases, as per the literature, majority of these cases, they were from the worst affected area. They have a lot of uncertainties. They become very introvert, and they live in extreme fear that what's going to happen next in these cases. I'm going to talk about a little bit about the post-acute sequelae of COVID-19 and neurological symptoms after COVID, and which can present months and weeks after the COVID infection. We can give them a different name, long haulers, COVID long haul 19, and sequelae of COVID-19. And some of these patients are also labeled as like brain fog syndrome. And we know that these patients, some of these patients can experience mental and cognitive changes a long time after the initial COVID-19 infection. And they can have psychological symptoms, they can have behavior changes, they can have poor attention span, they can have poor concentration. Their memory is not the same as before. And as I said before, some of these symptoms could appear as like subjective symptoms, but these are real, and we have to recognize them earlier, because these patients, they lose their productivity, they lose ability to do their daily ADLs, and they go into a depressive kind of state. And it's interesting that these symptoms, majority of these patients, almost like 50% of these patients were hospitalized with the COVID infection. And it can also happen in non-hospitalized patients, and it can also happen in asymptomatic patients, asymptomatic COVID-19 patients. And anxiety was the main entity, and depression followed by adjustment disorder, tic disorder. And causes, again, could be multifactorial, and persistent immune activation, and low level of virus surviving for a long period of time. There's a publication by Stefano and his group. It gives an interesting perspective that this viral genome, it incorporates itself into the mitochondrial matrix of the host cell. And this basically, it hijacks the mitochondrial genome, and it can stay in these mitochondria for a long period of time. It can replicate, and it can reduce the mitochondrial energy, and it can affect many areas of the nervous system also, because as we know that oxygen consumption, it increases as we go up on the neuronal axis. There's a minimum oxygen consumption in the spinal cord, and then higher in the medulla, then the midbrain, and then the basal ganglia, cerebellum, and finally the cortical structures. They require like maximum oxygen. Prefrontal cortex and temporal hippocampal area, it requires, they're very sensitive to oxygen depletion. And once the virus has been living there for a while, it reduces the energy. It can cause like that minimal hypoxic state in these areas, which can contribute to some of these symptoms. So it's very interesting to know how it can act. There's a big retrospective analysis published by Al Ellie in Nature, and these are the patients taken from like Veteran Affairs, and as we know, it's the largest database in America, and there were like 73,000 patients who were not hospitalized, and 13,000 patients who were hospitalized. They were interviewed and they were followed, and interestingly, they saw that these patients, they had higher risk of deaths in the near future, in months to follow. They followed, I think, up to 6 months to 8 months, and they had higher risk of outpatient care encounters, and the higher burden of neurological and neurocognitive disorders in these patients. and higher mental health and malaise, fatigue, non-specific symptoms in these patients. And the risk and associated burden basically it did not depend upon the severity. Even the non-severe cases had similar symptoms. But then again, more severe the case, the higher chances of these symptoms in these cases. So I think this was an interesting presentation, and they published in Nature recently. And this is again the probability of getting psychiatric illness and anxiety, mood disorders, anxiety disorders in people with COVID-19 infection when they're compared to the regular flu infection. And probability of these patients getting these illnesses are way higher compared to the influenza or flu infections. And this was published by Tachycardia, who's from UK in the Lancet Psychiatry. And I think this is also interesting fact. I was talking to Dr. Kairam, and he said something about, that this brain fog thing leading to chronic, something like chronic fatigue syndrome, an entity like that. So I looked up and I got interested in that, and I saw some similarities between chronic fatigue syndrome, fibromyalgia, and brain fog syndrome of this COVID-19 infection. As we all know, that fibromyalgia has maximum, widespread pain, and we don't need any like number of tender points. We need to have at least 4 out of 5 regions where they have unexplained pain. It's like left upper, right upper, left lower, right lower, and the axial body parts where they experience pain. And if they have 4 out of these 5 areas where they have unexplained pain, cannot be explained by the muscle and orthopedic causes. So fibromyalgia has more of these findings. Then fatigue is a common feature, maximum in chronic fatigue syndrome. They get fatigued very easily, even after doing like mental activity. Forget about physical activity, they get very fatigued. But even after doing simple mental activity, they get very fatigued, which is also a common feature with brain fog syndrome and fibromyalgia. All of these patients, they can have cognitive difficulties and alteration in their memory. They can have poor concentration. We have seen language involvement, especially comprehension in brain fog, and they have lower attention span, and they're not able to comprehend all the things they're told. And all of these patients, they can have postural dizziness. The last thing is the postural tachycardia syndrome. And many people have looked into this, and many groups are still looking into it. And interestingly, fibromyalgia can be associated with this condition when they're subjected to tilt table test. They have like tachycardia at in certain positions. And the same with chronic fatigue syndrome. And interestingly, patients with brain fog, so-called like brain fog and after COVID-19 infections, many of these patients, they have a similar finding on the tilt table test and like a postural tachycardia kind of syndrome. And who knows, as Dr. Kairam suggested, that in future, brain fog will be a separate entity, or it will be an entity with chronic fatigue syndrome kind of entity of fibromyalgia. So only time will tell, but definitely I think it needs more work and more experiments in this field. I think that's the end of my slides. Are we doing okay with time?
Yeah. We'll take questions. Are you done with your?
Almost. I really wanted to thank you for giving me this opportunity, and I wanted to thank you, Dr. Chelimuri, not only for this opportunity and presentation, but really being a role model and leader and guiding us through the pandemic so far. I know it's not over, and we still need to do some more work. But thank you for your help, and thank you, Dr. Kairam, for talking to me and suggesting that brain fog could be entity close to the chronic fatigue syndrome and fibromyalgia. And thank you, Dr. Sudhakar, for giving me this opportunity to talk and giving this presentation. Well, my dog Chase, he's 7 years old, and he's patiently waiting for that day to come when this pandemic is going to be over, so that he can go out and play with his friends, same as humans. So I think that'll be end of my presentation. Thank you so much.
Ram, you have to unmute your microphone.
Oh, I forgot. Thank you very much for an exhaustive account of this neurologic manifestations. As you and I both discussed, it would not be a surprise for the next couple of years. We'll constantly talk about brain fog and long COVID and maybe syndrome similar to chronic fatigue syndrome. The person whose face you see on the screen is Dr. Buchirazu. He is head of the Department of Neurology at this medical school. I had asked him to speak up and make some comments about his local experience. Dr. Buchirazu.
Yeah. Good morning, sir. Okay, good evening there. It's a very extensive lecture by Dr. Manjit. We thank him for his extensive lecture and covering from central to peripheral nervous system and the psychiatric manifestations. Just to add few things, actually we also saw all these different types. Maybe we didn't have on record because of these restrictions in ICU and all that. We didn't have a proper record, but we have seen some very interesting cases immediately after COVID. I remember one case, like as you mentioned, the patient had bilateral facial with dysgeusia. We had one case of 1.5 months progression of PCB variant of GB syndrome. Now, only interesting thing is she had a progression for around 6 weeks, and the upper limb weakness is grossly asymmetric, as you mentioned. She is from Rajahmundry. We treated her initially with IV methylprednisolone and IVIG. She has done well, and the NCV suggestive of GB syndrome. Only thing is, initial PCR was negative, but when you have done antibodies, they were strongly positive. Like that, I remember another case of focal encephalitis. Patient presented with occipital seizures and MRI showing occipital restriction. And this patient also responded. She is also diabetic, we don't know. And the antibodies were positive. Recently, we had one patient who was initially admitted in the COVID for encephalitis. At that time, RT-PCR was negative. And after a month, now we presented her with chorea. Actually, the initial MRI changes in the brain, multiple T2 hyperintensity are significantly reduced. But now she presented with chorea. Now we have done antibodies, they are strongly positive. So some of these patients came to us later on. So we don't know whether that is COVID because when we couldn't find any other cause when we were doing antibodies, they were strongly positive. Because of the pandemic, many people must have been exposed, and so antibodies becoming positive. So, probably we are seeing many such type of atypical presentations. We also saw mononeuropathies. Like I remember even a doctor presented a foot drop. Another 3-4 cases with single common peroneal neuropathy. One patient with radial palsy also we have saw. So as you mentioned, we have saw a lot of cases. I just want to ask your impression about, like many people ask questions like regarding vaccination. Patients on immunomodulatory drugs in myasthenia or in multiple sclerosis. What is your take on vaccination?
I think
Vaccination and
individual who's already immunocompromised or has MS, impact of giving vaccine. Now, I would ask Dr. Chilimuri also later on, have you had some experience with MS, for example?
Soumya,
I think we are still offering
webinar lo unnanu. Webinar
these
avutundi
patients
kada.
vaccination. And we have seen like there's a literature for patients who are on natalizumab, and I think those patients they tolerate these vaccines pretty well. I don't know about patients on other immunomodulators on MS, but we do offer them vaccines, and I haven't seen, maybe Dr. Elkin, who's our MS specialist, maybe she has seen such cases, and maybe I don't know whether she has any complications with the vaccine in these patients. Dr. Chilimuri, do you have any?
So no, we don't have any complications giving vaccines to MS patients or any chronic neurological syndromes. However, if you're giving CD2 depleting therapies like ocrelizumab for multiple sclerosis, then you have to time your vaccine appropriately. So if you give lymphocyte depleting therapies as part of treatment for MS, and you give vaccine at the same time, the vaccine is unlikely to be effective. So you have to find the right window. For instance, ocrelizumab, which is given once every 6 months. So if you want to give it, first give the vaccine, wait a month, let it work, and then give the vaccine, and then the second dose you could give a month later. So space it out by 8 weeks and give it, and you would be having an effective vaccine. Otherwise, we haven't seen any complications giving vaccines to any patient with MS or ALS or anything like that.
And Dr. Garuda, we also have a case with the bilateral brachial flexopathy, and we did the EMGs and MRI in this patient post-COVID, and we saw some inflammatory changes in the brachial plexus. We have put him on high-dose steroids, and he's really doing well. His left side is also like already improved to 5 out of 5. He still has deficits on the right side, with the right brachial plexus was more involved. But he is coming along, but I think he's still going to have some deficits. But we treated him with the high-dose steroids, oral steroids, prednisone, and I think I don't know whether the same is true for mononeuropathies in these patients you've tried.
Yeah. Actually, most of these patients already were given steroids when they came to us, and most of them have done well. We have seen quite a few number of GB syndromes, both post-vaccinal. We saw, I think, a couple of cases, and post-COVID, one of our patients who had GB syndrome in the ward had he had fever only 2 weeks ago, but again when we repeated RT-PCR, it was positive and was shifted to COVID ward. So post GBS also we had seen a quite good number of patients. Some have some, as you mentioned, some atypical variants. Only I mentioned that case interesting because she has progressed for more than 4 to 6 weeks, unlike typical GBS, and some very gross asymmetry, and not responded initially with steroid, and we are given IVIG with partial improvement. I remember another patient after the first wave, because at that time mucormycosis was not so prevalent. This lady presented with superior orbital fissure syndrome. The sinuses were normal, ENT examination was normal, the CSF study was normal, seen extensively outside, had multiple scans, presented to us after 2 months. She had only very minor changes in the orbit. Later on, when the ophthalmologist has done an orbital biopsy, it was turned out to be fungus. So that is the first case which we encountered. That is in last year, August, September. So, but peculiarly, she didn't have any COVID previously. Only thing is, we have done COVID antibodies, which were strongly positive at that time. So that superior orbital fissure syndrome, actually, some case reports are there initially at that time with ophthalmoplegia also. So we thought it's basically simple ophthalmoplegia, some demyelinating variant, typical variant. But on follow-up, because still the patient did not respond to steroids, several times was given outside and with us, by us also. And the changes in the orbit are very minor and signs are normal. So, but at that time again, because still persisting, some orbital biopsy was done and it turned out to be myocard. That is the first case which we have seen about myocard. Now, after the second wave, we saw a lot of cases, like typical rhino orbito. So, we have seen quite a good number of atypical, even post-vaccinal, I remember seeing brainstem something demyelination, one case of brainstem demyelination, but responded very well with methylprednisolone. Two, 3 cases of GB syndrome. Strokes, we have seen quite a good number after vaccination. Maybe that's because initially the vaccination was done for elderly. Many of them are diabetes and hypertensive. So we don't know, and none of them have thrombocytopenia when we were investigated at that time. So we don't know whether it is just an incidental finding because stroke is quite common in that population. So, but we have, like I think we saw 2 cases of CVT, which you mentioned post-vaccine. Those 2 are because young people and not much risk factors. This both responded very well with heparin and followed up with oral anticoagulants. So, and a lot of patients came with multiple, like in the follow-up, we're seeing with headaches, some fatigue syndromes with multiple somatic type of complaints. So some could be related to the post-traumatic stress disorder, and so we should be on watch. But really, we didn't see so much of like significant cognitive dysfunction on follow-up. Many of the what we came across are mostly like post-traumatic stress disorder. Maybe we have to keep watching most of these patients in the OPD.
So, Manjit, I think there's a question in the chat window, but the question is, it's a doctor who developed a burning paresthesias 1 month after he had COVID in December, has tried gabapentin and B12, still has persistence of symptoms. How would you go manage that?
It appears to be like a focal neuritis kind of picture. And I would say if gabapentin is not useful, then they may try something else like pregabalin sometimes helps, and duloxetine like Cymbalta. And if nothing helps, then I would try the other anti-seizure medications like Tegretol or something, or tricyclic antidepressants.
Yeah. Do you want to work him up or no?
Depending upon what part of the body the neuritis is. I mean, if
burning his feet, I think.
Yeah, burning his feet, then definitely I would work him up. I will look for like electrolytes, do the EMGs and the nerve conductions, and see what it shows.
Yeah. Yeah, I think the sudden development of neuropathies is a problem with COVID, and they come in all shapes and sizes. I think the acute Guillain-Barré, they are relatively easy to diagnose and treat because you're giving them high doses of steroids and plasma exchanges, and they do quite well with that. I think the problem comes when they develop these prolonged neuropathies, which develop days and weeks after they get COVID. So in them, I think there is no one reason why they develop them. So as Manjit said, I would do a proper workup and not jump to treatments like gabapentin and things like that, because we've seen case reports of nutritional deficiencies like copper and B12, and these are probably induced because of 1 year of pandemic. You're not really eating what you're supposed to. So something as simple as that, or to a triggering of paraproteinemias. So you could have abnormal paraproteins in your urine. And lastly, as you mentioned about demyelination syndrome. So I think before you jump to treatment, if it has some kind of a clinical correlation with a recent COVID, and I would also want to distinguish a vaccine is a huge thing. I think we can't ignore it. In this particular instance, it seems that he got COVID after that this happened. So in all of them, and many of them have diabetes as a risk factor to begin with, so you don't know what's causing what. So that's why I think rather than commit to various therapies, it's better to do a formal workup and come to at least the ones that you could exclude it, and then I would try all kind of things. I think the ones you mentioned are all reasonable, but just be prepared that in COVID, two things happen, that it could be vaccine that's causing it, and there are several cases of just vaccine causing some of the problems. So that's one thing to bear in mind. And second, you will be in for surprises, that what you think is a run-of-the-mill peripheral neuropathy end up being a paraproteinemia. And there are patients who respond with steroids, some will respond to IVIG, and a third group to rituximab. So that's why you want to really pin it down, get a diagnosis before you start treating.
No, yeah, definitely. And I would also say, like, sometimes, there's like presence of small fiber neuropathy, and especially as you said with nutritional thing. So if all the investigations have been negative, then definitely do a skin punch biopsy and look at the small fiber neuropathy.
Yeah. So Ram, you're back. So pick up the chat window and ask.
I was going to go back to a couple of questions that were there, but Dr. Prem Kumar
I took one of them, but you have to ask the others.
Dr. Prem Kumar first.
Hi, good evening, all of you. Good evening, and good morning to people in India. Actually, it's a little sidetracking, and I'll be putting forward my observations here. A couple of days ago, when the state expert committee was meeting, the pediatric experts, they were commenting that they were seeing a huge number of dengue plus COVID co-infections. And to put it in their own words, they say necrotizing encephalitis, especially occipital area, and a pediatrician commented that it is smashing the basal ganglia. And they're unable to differentiate whether it is due to dengue encephalitis or COVID. And they are confused whether to give, anticoagulation or not. And I'm bringing this observation because if you go through the news in UP, the hospitals are overwhelmed with children with dengue fevers and dengue encephalitis. So it's at least important for us. So can you comment upon this, Dr. Dhalu and Sridhar and others?
Fortunately, unfortunately, we don't see that much dengue here. And a quick question regarding that: if it is dengue encephalitis, do you see any CSF changes in these patients just with dengue encephalitis?
Really, I'm a pulmonologist and I sit in the state expert committee group as a pulmonology representative, and the pediatricians and pediatric intensivists were also there in that group. They were concerned about this.
I think it'll be
dengue encephalitis is mostly a serological diagnosis. Previously, we have done, because we don't get any dengue like virology test from CSF. Only probably in the main centers they are doing, but it's more of a serological with radiological and the clinical situation we diagnose dengue encephalitis. But as already Prem Kumar mentioned, it's more of a hemorrhagic encephalitis. But that is also seen with COVID, and thalamic involvement is quite commonly seen in most of our flavivirus, like both in Japanese, dengue, scrub typhus. So more of these changes are more common with dengue rather than in COVID, because we have seen COVID so extensively, but we don't see so much of changes on MRI brain, except in a severe COVID who are already in ICU with hypoxia and all that. So I think these changes are more because of dengue hemorrhagic encephalitis.
Just to add, in the pediatric population, we don't see COVID causing hemorrhagic encephalitis. Hemorrhagic brain disease is very uncommon in COVID in young people. So I think if you're seeing it, it's probably dengue that's causing it. It's less likely that it's COVID doing it.
Neither is a particular involvement of basal ganglia. That speaks more for dengue.
With dengue.
Yeah. Well, in the adults, COVID does involve basal ganglia too. So adults is a different situation, I think. But in children, I think it's a little more easier to distinguish it from COVID. In adults, I think it's a lot more challenging if you're faced with that. Yeah. But what we see now in COVID in the adult is the bleeding is mostly from use of anticoagulants, quite a bit of it. So we now don't use anticoagulants, number one, unless there's a proven clot, number one. Number two, if they are severe COVID and in the ICU, without evidence of clot, we don't anticoagulate anymore. We just give them prophylactic doses. Now, on the other hand, if they are mild to moderate disease in the floors, and they have COVID and elevated D-dimer, we do anticoagulate them. And in that group, there's no high bleeding complication. So it's quite different. But I think in the children, if you're seeing hemorrhagic disease in the brain, that is not very unlikely it is COVID. We haven't seen it at all. Yeah.
Thank you so much.
I think, Kairam, there are more questions in the...
There is one actually, after Dr. Dallu attacks it, I would like to take it too. What would be the treatment for severe fibromyalgia if it is seen following vaccination or following COVID-19 infection? Manjeet.
Yeah, I mean, it's fibromyalgia cases, and some of these cases are really difficult to treat, as we all know. We can try multiple things, and I think personally I would start with simple things like gabapentin or pregabalin, and some of these cases I have like a couple of fibromyalgia cases very stable on duloxetine, Cymbalta. And Savella is also a choice in these cases who are not responding to gabapentin and pregabalin. But some of these cases, I don't know what your experience is. In my experience, they're very difficult to treat. And initially, to be very honest, like I got trained at Montefiore, and Dr. Schomburg, he was a chairman there. And he never believed in this diagnosis of fibromyalgia and chronic fatigue syndrome. But subsequently, we have like more literature and more findings. I think initially, even I did not believe in this diagnosis. But now more and more literature and more cases we see, I think it's real in these patients. But in my experience, I think things like gabapentin, pregabalin, duloxetine, and Savella are the mainstay of treatment for this. I don't know what your experience is.
It's fair to say a large percentage do not respond to therapy.
Yeah.
It could go on for many, many years. Yeah. And when the anxiety or the depression goes away, the fibromyalgia goes away. So it's a difficult condition to deal with. And yeah. It's not easy to say treatment A works and treatment B does not.
Yeah.
But it's a frustrating condition for a lot of people and physicians.
Yeah.
But again, because I'm internist and you both are neurologists, we look at things differently. A vaccine triggering fibromyalgia is very unusual. So I would urge you to do a workup. They could develop suddenly autoimmune disease of certain kind, like thyroid disease, after vaccine. So I would work it up, establish a diagnosis before assuming that's fibromyalgia. I have not seen it. We've done 60,000 vaccines, so it's 80,000 now. I've not seen a single case of vaccine-induced fibromyalgia. So I think if you're seeing a new onset of symptoms after vaccine, it requires a workup.
There is
There
another
are more
question.
questions.
The other question might end up with you, Dr. Chilumuri. Can we take booster dose of COVID vaccine 6 months after taking the second dose on our own? Any vaccine is okay, or the same vaccine which we took earlier? May I answer this question first? I took the third dose 2 weeks ago, 0 side effects except for a feverish one night. But my recommendation would be, if you took COVID, take COVID again. If you took Pfizer, take Pfizer again. Stay with the same vaccine. What do you say, Dr. Chilumuri?
I think we are in a controversial area. Number one, the way I would go about is, I think Kairam is over 60, he's male. It's an easy call to say anyone who's a male over the age of 60 wants to take a booster vaccine. I'm not against it. I think the data supports it. Breakthrough infections are more common in males over the age of 60. Because they never produce enough antibodies to begin with, like women do. So therefore, I think in them, it's fine. In the United States, we're recommending it 8 months, but that might change anytime. Number one, we want to know what kind of vaccine you took. There are some vaccines, for instance, the Chinese one, the Sinovac and the Sinopharm, been substandard. The efficacy has been pretty low. As low as 60% in several countries. So in them, it's an easy call to make that they should get a booster dose. In India, they used mostly AstraZeneca. The recommendation is you can use it anytime 6 months. In Israel, they've used it as early as 4 to 5 months after the second dose. There's data suggesting that if you take mRNA vaccines, for instance, and they're supposed to be 95% efficacious, right? In healthcare workers, and I'm assuming the person who's asking is a doctor, in healthcare workers, efficacy dropped to 84% 4 months after the second dose of vaccine. So it wasn't 95% at the end of 4 months, both for Pfizer as well as for Moderna. So if the most effective vaccines that we have currently drop their efficacy after 4 months, so taking it at 6 months is not a difficult decision to go ahead and take it. The challenge is what do you do about young or younger women who are below the age of 50, let's assume, who generally produce very good antibody responses. Women respond better to vaccines than men, and this is applies to all vaccines. So they also, unfortunately, have a higher rate of developing complications with vaccines, albeit they're very rare, and I'm not saying don't take vaccines. What I'm saying, what few complications that we've seen, including thrombosis, Guillain-Barré's, and for that matter, myocarditis, we're all seen in women below 50. Now, on the other hand, what is the risk of them developing severe illness? If they have no medical problems, women below 50 have generally done very well with COVID. And if they've got 2 doses of vaccine, they have no active medical problems, they don't get severe COVID anymore, at least the 8 months after vaccines. That's the evidence we have. There's a slight increased chance that they could have a complication with the vaccine itself. So I think in a woman with medical problems, diabetes, hypertension, things like heart disease, I think there you could go and take the 3rd dose would be reasonable. So in the United States currently, they tell us to take the same vaccine as you got in the first 2 doses. So currently only Pfizer has been approved for 3rd dose in the US. So if you had 2 doses of Pfizer, your 3rd dose will be Pfizer. for Asians who came to United States, we mixed vaccines. They have taken AstraZeneca in India, and then we gave them mRNA vaccines, and we have not seen any adverse events at all. So mixing of vaccines doesn't seem to have harmed anyone. So I think if mRNA vaccines come to India, since you all taken Covaxin or AstraZeneca vaccine, I would switch to an mRNA vaccine just because it's far more potent, far more efficacious than any other vaccine. So that's a long answer, no definitive answer, but that's what I would do. I think in some categories of people, it's relatively easy to say, go take the third dose. I think healthy people with no medical problems who are young, who gotten 2 vaccine doses, I'm not so sure we have data to recommend a third dose.
Sometimes patient asks the doctor, doctor, if this was your brother or wife, what would you do? So Dr. Chilimuru, you're almost 60, you're male. What did you do?
I have not taken the third dose yet because in New York, we're still not given access to take it yet. So I know Texas does whatever they like, but the FDA hasn't approved it until September 20. So we think we'll get it. And would I take it is the question, right?
Well, I was curious. On September 21st, would you take it? Yeah. But
any role of checking the spike protein antibodies before getting the third dose?
Yeah, so I do it. That's how I handle it. What I've noticed is that the titer is going, in some people, titers are going down. They start with fairly high titers and they keep going down. And each assay is a different number, so I don't want to use a number because in one assay, the 100 is the number. In the assay we use, 200 is the number. In our assay, what we've seen is if you follow a person and if you keep seeing their titers are going down at some point, like below 100, below 200 in our titer, at 150 people got breakthrough infections. So I think if you're doing titers, if they're going down, you should take the booster dose. For somebody like me, because my titers went up because I'm being exposed to patients, obviously that's why my titer went up. So it's a little more difficult question to decide when should I take the booster dose. Should I take it September 21st or can I wait? I'm still thinking about that one. I am, as you said, getting close to 60 and a male. I think it's easier if you definitely have risk factors to take it.
Or continue getting like low dose exposures?
I do monoclonal infusions, right? That's when we spend an hour with the patient who's COVID positive. So I'm pretty sure no matter how much PPEs you use, one thing you will notice with Delta is that they cough a lot more than the non-Delta variants, number one. Number two, it's a wet cough. So other than the changes in the spike protein, which increases the transmission rate, it's also, they cough a lot more. So I think no matter the best of our efforts to wear PPEs, I'm pretty sure I'm still getting a little bit of exposure. Yeah. But I'm pretty sure at some point I'll take the third dose. I think there are other questions.
Yeah, one. Go ahead.
There's an AIDP after vaccine. How would you, can you get AIDP after vaccine? That's the question, Dr. Thaler.
Yeah, I mean, we haven't seen any cases, but it's possible, like with these viral vector vaccines, people may get can get AIDP syndromes, but definitely, again, as you said earlier, we need to be sure that this is a real syndrome. We need to work them up and find out whether it is AIDP or something else. And but I think I haven't seen, checked the literature, like not with the mRNA virus, but with viral vector vaccines, it is a possibility.
Yeah. Yeah, I
Sridhar,
think that case reports of it. Yeah.
Sridhar, I was missing for 5 minutes. Did you address the question from Dr. Mahesh, who's having
Yeah.
severe foot pain?
We
Okay.
did.
Yeah.
We did. We
Okay.
did address that. Yeah.
All right. Dr. Dhalu, usually we go for an hour and a half because beyond that, we might lose attendance next time. I thank you very much for speaking tonight and having addressed it in such a wide, broad approach, both acute and chronic. Dr. Sridhar Chilimuri, thank you for finding us, Dr. Dhalu. Dr. Sudhakar, your turn.
I just want to make one final point. I think as you as it relates to neurological diseases, as India vaccinates more and more people, and you're doing a tremendous job. I think now you're doing, several hundreds of thousands of doses a day. So clinicians will be facing whenever your next wave or whatever that comes. So every time you see a patient of a neurological condition, one is it could be the usual stroke or the usual neurological disease. So that's one differential diagnosis. And the second is it could be COVID, in which case, obviously, testing them and you will know about it. But also remember that it could be vaccine related. So vaccine complications cause the same things. You get acute stroke, you get neuropathies, you get post-fatigue syndromes with the vaccine. So it becomes diagnostically more challenging in the coming year on how to delineate cases. So every time you see a patient, make sure you take the history that have you been vaccinated, and don't ignore it just because they got the vaccine 3 months ago. We have seen complications occur at any time. So it's always one of your differential diagnoses. So, and as you go, more and more people getting vaccinated, it becomes more and more an important differential to think of. COVID, or is it vaccine, or is the usual illness? That's all I have to say.
Thank you. Dr. Sudhakar.
Thank you very much, Ramohan, and a wonderful session that we had today. And thank you, Dr. Manjit Dhalu, for covering the entire spectrum of neurological manifestations in COVID-19. And thank you very much, Sridhar, for those expert comments. And as you are all aware that this is the 86th episode of our continuing medical education programs on COVID-19. And we'll meet the next Sunday at the same time. Thank you all.
Thank you so much for having me. Thank you.
Dr. Dhalu, Dr. Bucharaju, thank you for hanging in there.
Yeah, thank you, sir. Thank you.
Sridhar, good night.
Okay, thank you.
All right.
Bye-bye.
Okay. Good night. Bye-bye.